And we're live on Facebook.
Thanks, Nikki.
Welcome.
Can I welcome everyone to this session then? So we are continuing our conversations around Black, Asian and minority ethnic staff, particularly in light of COVID. And particularly today, we're going to be focusing on the vaccination of the workforce and the population. And in a moment, we're going to hear from some very wise colleagues who have an understanding and insight into this topic, and we can respond to questions. So we'll have a short presentation from each panel member, and then we will go to the questions from the floor. So welcome. We have up to an hour together. We will record this session and make it available to wider communities. I hope it's useful. I hope it's a really useful, informative session. So my name's David Werrett. I'm the Workforce Director at Cambridge University Hospitals. I'm going to chair this session. There's a few things I wouldn't mind saying before we start. I know we're joined by people from the Cambridge and Peterborough system, and perhaps people will view from beyond the system. So apologies if we talk a bit about Cambridge itself and Cambridge University Hospitals. But I think we all as employers share our commitment to staff health. And by staff health, we refer to all of our staff and all members of the family who do amazing things in our organisations. So this is part of that commitment. We know, and we've had such horrific stories of minority groups, including Black and Asian minority ethnic staff, suffering disproportionate harm. And again, this is why we're having these conversations with that particular focus on keeping that staff group healthy and safe as we go forward. I just wanted to share as well why this is so important to us right now. So we hear stories of disproportionate take-up of COVID vaccines, and we'll talk a bit about that during this session. And specifically, we're starting to get data through our own vaccination hubs in Cambridge around that pattern. And within Cambridge University Hospitals, of the workforce, about 50% of our staff have chosen to take up the vaccination so far and join through our own vaccination hubs. But I have to say, if you bear that 50% of staff in mind, the position on every one of our minority ethnic groups is less than 50%. So if I may, the position right now amongst people who identify as Black African is 17% take up. Amongst Chinese colleagues, 29%. Filipino colleagues by origin, 29%. So the numbers are, we monitor them, we track them, we want to understand what's behind that, because we want everybody to make good decisions. And we believe a good decision right now is to access the vaccine, which is being made available. So this is important. It's part of the health and safety agenda, and we want this to be understood and shared, and for people to make good, informed decisions about their health. So the panel this afternoon, we in this order, we will hear from Tracy Cripps, who's the Vice Chair of our BAME staff network, and also works with us in R&D governance. So brings a particular angle to this and a particular level of wisdom to this, which is great. Then we will hear from Dr. Habib Naqvi, MBE, I should say. Congratulations on that. We're delighted you can join us from your national position as the Director of NHS Race and Health Observatory, and a very, very unique angle you bring to the conversation this afternoon. Then we'll be joined by Ravi Balakrishnan, PhD consultant in East of England, who, again, a very important role at the moment. If public health isn't the focus of all of our lives, then I don't know what is. So thank you, Ravi, for joining us this afternoon. And last, we will hear from Dr. Mark Toshner, who's a clinical fellow here in Cambridge, a pulmonary vascular physician and investigator, and involved with the Oxford vaccine, I believe, quite intimately, Mark. So thank you for bringing that to us this afternoon. So what we're going to ask each of our panel members today is to talk to us for about 5 minutes about their particular perspective on this, on the challenge of vaccination of our staff, and particularly as it relates to Black, Asian, minority ethnic staff in the NHS and in Cambridge. If my colleagues, because they've got a lot to say, go over their 5 minutes, I'll sort of wave frantically and try and ask you to come to a close, because we want the main chunk of this to be responding to questions. Now, Nikki, you're on the call. Can you explain how people can lodge questions for us over the next few minutes as we talk together?
Sure. So there are two options for questions. For those who have joined us via Zoom, there is a lovely Q&A box at the bottom of your screen. If you could just log any questions that you have in the Q&A box. Please do not pop questions into the chat, but if you do, I will just remind you to pop them into the Q&A box. And for those who are joining via Facebook, I will be keeping an eye on the Facebook comments. So if you could just write your question in the comment section, and then I will bring it to the attention of the speaker, and we will take it from there.
Great, thank you. And can I encourage people to be very open if it's required with their questions? We're not crawling over who said what and why. This is an opportunity to ask questions of some very wise and informed people. And it helps us to understand the issues that are going on with our workforce at the moment. So I'm rambling on far too much. Tracy, can I hand over to you to start? From your perspective, how are you viewing this? Thank you very much.
Thank you very much, David, and to the panel for inviting me to speak. This is a matter that is so close to my heart, and something that I actually raised in the BAME network probably August, September time. But before I even touch on anything else, I think I'd have to just make an acknowledgement of the 100,000 deaths that we're all mourning for at the moment. I think nationally the whole country is in mourning, and it's a shocking statistic, and obviously the NHS is at the heart of it. So you know, our hearts as a trust individually just goes out to everyone. I've endured personal losses myself in my family. This issue, I think, is multidimensional and, you know, multifactorial. There's not one explicit element or thing that you could point to as the reasons for this. And, you know, I'm going to touch on a few factors, sort of looking historically to the past, presently, and what we can perhaps just touch on and start thinking about in the future. I think in generally, there's been a lot of antipathy around vaccinations in the BAME community anyway. There's a long historical documented pathway that you could research on things like rubella, pertussis, and probably the most famous ones of those is Tuskegee, and what happened there with American Blacks being either given syphilis or deliberately being withheld treatment for syphilis, even though the, you know, identified and, you know, authorized treatment at the time was penicillin. That disease was allowed to progress. They infected their partners, children, you know, second, third generations were still feeling the effects of this. So I think those issues and those historical things have never really been addressed, and I think are very much deeply rooted, you know, throughout the world, across the BAME community, wherever you sit, whether you're of Caribbean origin or African origin or wherever you sit on that plethora, that story, that historical wound is still there and is quite raw. So that in itself is kind of a bit of a foundational pillar that has provides the mistrust. So in general, as I said, because of these historical factors, the antipathy around vaccines, because of these historical atrocities that took place, there's that there that we're dealing with, you know, facts. So that's difficult. And I think presently we've had quite a few different things to deal with in addition. So not least because of what happened with George Floyd and the Black Lives Matter campaign, that, you know, just engulfed, you know, the country along with this pandemic. And again, we're still finding that to present day, you know, there are still these racial tensions and racial issues that are happening that impact not only on social and economical elements, but again, sort of feed and develop mistrust in, you know, the BAME community in terms of hidden agendas and how people in the BAME community are treated. I mean, just recently in January, following on from George Floyd, there was another sort of movement, which wasn't that publicly in the media, about Mohammed Hassan, Habib and Dr. Nakvi. I don't know if you've heard about that, but that was another sort of rumbling of a young man that was held in police custody and sort of passed away shortly after. So, you know, there's this constant drive and feeding of a bit of a beast in in the social structure, in the social systems, in the government, that you know, breeds a lot of unfactual and unfounded views. I think this is really substantiated as well by social media, because now people are in a situation where they have access to information. Some of that information that out there is true and is factual, but then that is also bred and mixed in a concoction with half-truths, myths and fables. So that then, when you're talking about the BAME community, who are quite frequently often on the fringes of society anyway, and in disadvantaged or disenfranchised positions, that information that is in social media then becomes the truth, because there is no other version of the truth if they're not in a professional sector or not receiving any support in any other government guideline that they can rely upon. What they're accessing in social media then therefore becomes the reality and the truth of the situation, which blurs and muddies the waters further. So I think it, you know, all of that really puts us in a situation where our foundations and what we're trying to do and the good work that we're trying to do with the vaccines is almost built on a foundation of quicksand, because you've got a whole host of propaganda that's out there in the media. You've got historical facts which have wounded the BAME community and have never really been addressed. And then you've got a current situation where the government themselves, in terms of being held to account over some of the decision making around vaccine policy, you know, people have a lot of mistrust around that anyway. So all of that coupled together, I think, has had quite a significant impact. And I think, you know, I don't mind sharing with you personally that the race inequalities, you know, as a trust, I'm really proud to be the vice chair actually of the BAME network and the work that we're doing. And I'm really grateful that the trust has committed, and some of the initiatives that we've put in place, and we've got plans to do a lot more. And to be fair, we've achieved much, but we still have much of a distance to go in terms of where we need to get to in race equality standards. But dealing with these inequalities, I think, is for the future part of the work that we need to do. There is a lot of mistrust. My son, we live predominantly in a white area. My son is one of 3 ethnic minority children in his year. And in English, they are doing Of Mice and Men. And it's, you know, that book is obviously of a particular era in America, and it uses very inflammatory and derogatory language and tackles some real racial issues. And actually the teacher was totally and wholly unprepared for the way the class was going to respond to feedback that came. And my son was actually in quite an exposed and vulnerable position. So even, and this happened, you know, a couple of months ago, they're studying that book now in school. So that's just an indication of going right back to Tuskegee, right through George Floyd, right through this pandemic, right to a 13-year-old boy who is at school now, present day, and we are still dealing with these inequalities, microaggressions, lack of education, and how this impacts on some of the decisions. And obviously, when you throw in the mix of that a worldwide pandemic, fear, propaganda, myths, fables, half-truths, all sort of goes into this soup, which doesn't really help us moving forward. So from a research, I know I'm at my line, if I can just finish, David. From a research perspective, I think moving forward, what we need to do is to myth bust and to tackle these things. How we do that is building bridges. How do we build bridges? We need to engage with people in the BAME community, bring them into research, develop more and do more in our patient and public forums, and just be open and honest. I think where we've made mistakes, we be honest and we build trust that way, not trying to cover things up. We just build relationships, we engage with the community, and I think that will go forward to start healing some of the problems that we're dealing with. I recognise there's a lot more to say, but I'll stop there and hand over, I think, to you.
Gosh, Tracy, thank you. Such a powerful introduction to that, and a reminder about the 100,000 yesterday, which I should have mentioned. So thank you for that. Should we hand over to Habib? Again, I'm going to be brutal with the stop clock because much could be said, but over to you. Thank you, Tracy.
Right. Thank you so much, David, and thank you, Monica, as well, for inviting me to your webinar. So I've been given the task of setting up and running the NHS Race and Health Observatory, and I'm in week 11 of that role, working mainly as a one-man band at the moment until my newly recruited people start. But it's been a bit of a roller coaster in the sense that when we started off on the idea of an observatory, we were in February 2020, and Simon Stevens gave his full support and endorsement for the observatory at a particular conference. And then 2 weeks later, we had the onset of COVID, which I guess in a way accelerated the need and necessity for an observatory, because we know that there are ethnic differences in relation to access and experience and outcomes across a range of different conditions and diseases that we would all be familiar with, whether that's cardiovascular disease or diabetes or mental illness. But of course, what we've seen is the onset of a pandemic, COVID-19, and the disproportionate impact that that has had and continues to have on our Black and minority ethnic communities and staff. So there is a level of urgency here. And so whilst I've been setting up the team and the board and the architecture for the observatory, I've also been focusing on what is it that we can pull the trigger on quite kind of immediately in order to have a positive impact upon our diverse communities. And I'll come on very briefly into a number of pieces of work that we've got in train already to look at some of those things. So I'm going to very briefly talk about three things. Firstly, the prioritization of Black and minority ethnic people in terms of vaccination. Secondly, talk about engagement and people. And then thirdly, look at the idea of places in terms of vaccination, and also look at how we can increase community support in this. And then firstly, as Tracy rightly highlighted, we cannot escape the very sad reality of the now over 100,000 hospital deaths from COVID. But what we can do is learn lessons from the previous waves of the pandemic and draw insights from the evidence on how the virus is impacting upon our diverse communities and potentially increasing inequalities. We have had several official reports produced since last March on COVID-19 and its impact upon BME communities, but we need better planning and we need clear action to protect and prioritize the communities that are most at risk clinically from the disease. Now, there is a significant risk that the vaccine uptake for COVID-19 is lower amongst minority ethnic groups, and the figures that David, you've given us are probably in line with what we're hearing right across the country. And what we need to do is better understand some of the barriers and be better enabled to address some of those barriers in terms of vaccine uptake head on. Now, recent survey data, for example, from the UK household longitudinal study, shows that actually the overall willingness around the vaccine is pretty high. So generally is around 80%, but there are marked differences by ethnicity, including, and I think this is in line, David, with your list, Black ethnic groups most likely to be vaccine hesitant, followed by the Pakistani and Bangladeshi groups. But what we do know is that at the moment, the most at risk, the vulnerable and healthcare staff are being invited to receive their vaccine. And this is in line with the JCVI, the Joint Committee for Vaccine and Immunization guidance. But when it comes to prioritization, and lots of people and groups are saying, you know, why aren't BME people prioritized as part of the tier system? They aren't, but based upon clinical risk, perhaps they should be. But what is already in the JCVI guidance is clear advice on focusing on inequalities, including by ethnicity, identifying those and addressing those in the implementation of the vaccine program at local level. So there is that clear advice. What I would suggest to the JCVI is for them to evaluate how well people are following that advice, and if they're not, to reaffirm that particular piece of advice with a level of urgency, and that's the position of the Race and Health Observatory as well. Now, what would support potentially the uptake, confidence levels, and trust amongst BME communities around the vaccine is for people, and especially at local level, to have an understanding of vaccine uptake by ethnicity. And it was announced, I think yesterday, that NHS England will start collecting and hopefully start publishing that data openly, so that we can better meet the needs of our diverse communities, both in terms of the messaging that we put out, which needs to be culturally appropriate and sensitive, but also the root of that message and the delivery of that message as well, because we need to look at more diverse and community-based vaccination centres and hubs across the country. So it's all good having your sports halls, council chambers and conference centres, but we also have temples, mosques and synagogues across the country. And these are community venues that really do need to be tapped into, because they're accessible venues, they can accommodate many people, they can increase the confidence and trust levels potentially of the diverse communities that we have. So data collection is absolutely essential. The final 2 points, firstly, on the fake news bit, we know that fake news, misinformation is doing the rounds and is scaring some members of the BME population into perhaps not taking up the vaccine. But we need to be absolutely clear that if we have both a top-down approach, which we are having at the moment, but also more of a bottom-up approach where we actually engage with our community leaders, faith leaders, community champions, people that we trust and have confidence in at local level, then we will be better placed in order to make sure that people have the accurate, factual information around the vaccines and are able to make reasoned judgments around the vaccination uptake, as well as listening to experts such as GPs, nurses, pharmacists, and healthcare professionals as well. So
we're almost at time.
Okay, so the final point, the message, I guess, is clear that the vaccines have gone through a necessary, rigorous regulatory process. They are safe. They have been developed at lightning speed, but they have been developed at lightning speed to prevent transmission and to prevent death. Thank you, David.
Thank you. Gosh, you were able to follow my instruction there really, really well. Thank you. I'd be sorry to cut you off in your almost prime. Thank you. Can we turn to you now, Ravi, from the Public Health England perspective, that profession which has become so important to us right now. So from your perspective, can you give us a few minutes?
Yes, thank you, David, and thanks for all the expert speakers as well. So I'm Ravi Balakrishnan from Public Health England. I just want to start with a sentence and then few evidence, and then I'll try to finish off as most probably in 5 minutes. So improving COVID vaccination rate among Black, Asian and minority ethnic groups is one of the best options we have in order to tackle disparities in risks and outcomes of COVID pandemic, which is affecting us. The reason why I see that is important is nearly 1 in 20, that is 4.5% of our English population is BAME community. However, in NHS workforce is 1 in 20, almost 21% of our NHS workforce belong to BAME community. And our community are engaged more and more of frontline services, either in NHS or in community as well. Even if you take in your own NHS practice, wherever you are, in A&Ds or any community nurses, school nurses or health visitors, high proportion are BAME community. So we are in frontline mostly. So the current evidence also shows, you might have seen, especially with the COVID pandemic, BME communities or BAME communities are disproportionately affected by this COVID pandemic. So our Public Health England reports clearly says that we are more likely to be diagnosed with COVID, and the death rates are highest among BAME community and also in deprived areas. And majority of our people also live in deprived areas. Just to say a few figures, our Bangladeshi community are twice the risk of dying from COVID when compared to white British. And the rates for other communities range from 10 to 15%. That is 10 to 15% greater risk of death from COVID among people with Chinese, Indian, Pakistani, Black African, or Caribbean, or any other BAME communities. Why this is important? Actually, this was reversed before this COVID pandemic in the previous years. For example, mortality rates were lower among BAME community when compared to ethnic, white ethnic community on specific conditions like chronic kidney disease. This is before, like 2 to 3 years before. Now it's totally opposite because of this COVID pandemic. Why vaccination? So overall, the childhood vaccination is really good, but the uptake of some vaccine is very poor among some individual BAME community. And you all heard about herd immunity. That is one of the ways where we can actually protect our community. But what happens with the BAME community? So we all live in certain groups, which we are not spread across the whole of the England. So either in the village or in the town or even in cities, we actually live in very big groups. Either if you take Leicester or Bradford or anywhere, we live in big groups. Let us assume like high proportion of these people are not vaccinated. And if the infection goes in, it spreads rapidly and the whole community will be affected. So in order to build our herd community within our community, we all need to be vaccinated. The next one is we all have sort of a ties with our own community, where we are coming from. So once it's relaxed, we go back to our own community, our own country, either Africa, India, or wherever. The prevalence may be high. The more chances of us picking up the virus in our own country when we go there, after it's relaxed, if you're not vaccinated, you have more chance of picking up different strains of virus there, or the same strain of virus there, because you are not immunized. When we come back, we'll be importing the virus here in this country, and then we'll be spreading across within our community while we are living in England. And also we'll bring our families here, our parents. So either if they come here and they might bring virus as well. Because of the ties, the more chances of getting virus in as well. And we all come up with the baggage of sort of where we are brought from, pre-knowledge, the religion, the caste, or the upbringing. So that all as some sort of a beliefs in us, which should not actually affect our sort of vaccine taking in. So the recent evidence shows some sort of a vaccine hesitancy related to COVID vaccine. For example, almost 13 times among Black African, they're less likely to take COVID vaccine when compared to other communities. And that is same with Pakistani and Bangladesh, it's 2.3 times more vaccine hesitancy in this particular community. So based on all this, I think the SAGE as well as the King's Fund really highlighted this vaccine hesitancy disproportionately affecting BAME community, who are already disproportionately affected by this pandemic as well. So what we are doing in PHE, first of all, we've done a lot of information and knowledge how it's affecting. Now we are setting up what we call as a National Task and Finish group led by Alika, our Regional Director of Public Health, who will be bringing people together under Chief Medical Officer's office in order to develop and show the leadership nationally and drive and support the local leaders who can actually have some sort of a local actions in order to make a difference to improve vaccination locally among BAME community, which can reduce the inequalities and improve the uptake. Thank you, and stop here. You're on mute, David.
How many times have I been on mute? Thank you. A really powerful overview of that, including the data. It continues to prove or demonstrate what we're trying to address and discuss here. So thank you. Can we turn to our final panelist this afternoon, which is to Mark, and with a particular focus, I guess, on the knowledge about the vaccine and some of that technical stuff, which you will now magically help us to understand.
I will, but first of all, I'm gonna make a confession. I'm the cuckoo in the nest here. I shouldn't really be here because normally I'm a university lecturer in a really rare condition called pulmonary hypertension. And until this year, the only two thoughts I'd ever had about vaccines were the grumpiness of having to have my flu vaccine every year because I always feel rotten for a day or two, and the annoyance about the fact that my wife won't take her kids to be vaccinated. So whenever my kids need to be vaccinated, I have to take a day off work. And so that, the reason that changed was this year, the Oxford vaccine trial needed somebody to run the Cambridge part of the trial. And that's what I do. I'm quite good at clinical trials, but I have no interest in vaccines before this. I have no career in vaccines. I've never received a penny to do any vaccine study. And I'll be absolutely delighted to drop it like a hot potato the minute it goes, because what I hadn't realized was the next 10 months, I would do nothing but think of vaccines and worry about them. So I ran the local trial and also the overarching group that looked at vaccine studies in Cambridge. And that was a really early harbinger that we were going to have a problem in the BAME community, because Esty Torok, who was my excellent colleague who helped me, and I personally went through all of the applications to that trial. The Chaddox trial was in healthcare workers. We had about 1,000 people volunteer for it. We had a very, very low volunteer rate from the BAME community. So from the very off, it was clear that some of the concerns about vaccines and BAME were going to be a reality. In the end, in the UK arm of that trial, we only managed to get about 6% BAME representation. And so although that fits nicely with the overall population, as Ravi very elegantly described, it's a massive reduction compared to what it should have been, because about 20 to 25% of our workforce are represented in the BAME community. However, in the trials, half of the participants came from Brazil, where they had a much better representation. In fact, about 30% of that Brazilian study, which is just slightly smaller than the UK study, came from a BAME background. And in the Pfizer trial, it was even better, because Pfizer was about 40% of the whole trial were from the BAME population. So actually, we have a lot of really good evidence in BAME populations of the efficacy of vaccines, which is one of the concerns that people raise. And really, it's something you don't need to be concerned about, because the data is there for both the licensed vaccines. So when I took that on, what surprised me was, when speaking to my friends and family, quite a lot of sensible people, bright, sensible people, had a lot of problems and concerns that they voiced to me. And quickly I began to realize that some of the hesitancy out there is perfectly reasonable. It's just people being cautious or having questions that they want answered. But quite a lot of those questions are answerable. And so I've kind of spent the last 9 months through a variety of different means just trying to answer simple questions about vaccine safety where we actually have answers. And a couple of the easiest ones to address before we even come to the questions are about the speed. I think Habib referred to the speed of the trials. So the trials were incredibly quick, and you might have heard this idea that it normally takes 7 to 10 years to develop a vaccine. But what people really don't appreciate is most of that time is spent doing nothing. It's spent trying to get funding. It's spent battling systems that are not very flexible. It's spent trying to recruit people. And in these studies, essentially, we got unlimited money, unlimited resources, and all the normal hurdles just got cleared away. So it was a little bit like being in the centre of London during rush hour, and instead of the usual frustration, you're given a police escort, all the lights are turned from red to green, and all the traffic's cleared out the way. That did not impact on safety. And in fact, I would argue the trials were even safer than they normally would be, simply because the whole world was watching. I had a horrible moment where I thought I might have a patient with a side effect. And what we knew was that you get one event in these trials and it's headline news the next day. The whole of the world knows about it. And if you think back to how many of those headlines you actually saw, there were a handful of them. And that just represents how amazingly safe the trials have turned out to be in the end. So I'll be very happy to talk about any aspects of vaccine safety or the trials, but it's important that people realize I'm not actually a vaccinologist. So I think that's a positive thing, because it means I don't come with a huge bias, but it also means that I've had to kind of learn very quickly on the hoof over the last 9 months. So most of my time has been spent reading about vaccines, and it's not something that I normally, think about. And that's me in 5 minutes. You happy with that? You're on mute, David, again.
That was you in 4 minutes, Mark. Thank you.
No.
Ah, look at this.
I timed it.
Right. Let's turn to some questions then. Let's have a conversation on the basis of what the audience is interested in. It would be lovely to see all of the people who are on the call at the moment, but we are where we are, and we will pass messages through and read them from the Q&A button at the bottom of the screen. Indeed, we've got some to focus on that we had in advance of the session. So if I can start with, there's a number of questions about safety, Mark, and I think you've covered that. About from your perspective as involved with the trials. So safety, is it perfect? Is a really good question. Is it fail-safe? And then the one about Oxford versus Pfizer. I wonder if you could take us through those.
Very happy to. So what's really important here is that you've got to remember, we're not talking about the option of having a vaccine versus not having a vaccine. It's having a vaccine versus the risks of having COVID. So far, the side effects from the very large vaccine trials, and Pfizer and Chadox are ones we're interested in because they're the vaccines we're being offered, demonstrate no real excess of anything other than short-term side effects. And that's in the first day or two when you feel a bit rotten. So far, no safety signals have emerged. But that doesn't mean that there aren't rare side effects. And so some people have pointed to possible autoimmune associations, and some people have pointed to some very, very rare things that happen in the region or frequency of 1 in 100,000 or 1 in a million people. And it's really hard to be clear on that until you've done millions and millions of people. The thing to remember is you're comparing it to the risks of COVID. So we know vaccines are safe. We don't know that there aren't very occasional, very rare occurrences, and those will become apparent if there are in the next kind of year or so. But 20% of people with COVID are still unwell, and somewhere in the region of anywhere between 1 in 10 to 1 in 100 die in our kind of populations. And so you're not thinking about it as the risk of a vaccine versus not having it. It's the risk of a vaccine versus having COVID. And regardless of what population you sit in, it doesn't even matter if you're the very lowest risk. Having a vaccine is still safer. And it's just simple observational data from the trials and from COVID itself. So from a safety perspective, there's only really one choice, and it's that straightforward. It's have a vaccine. But the concerns are reasonable and can be addressed with the data from the trials and from the real world.
And Mark, we're all obsessed with Oxford and Pfizer. Suddenly these things have become part of our language. Is there anything you want to help us with on that?
Yeah, just take a vaccine. It doesn't really matter which one, because they're both safe. The Oxford vaccine has so far 0 events of people being admitted to hospital seriously unwell, which on an individual basis is what you really want to know. You want to know, is it going to prevent me being unwell and dying from this? And the answer is unequivocally yes. And our latest paper that will come out will show you that's holding up for the bigger group in the longer term. Still 0 people have been admitted to hospital who have had a vaccine. The same is basically true for Pfizer. When you look at the efficacy rates, you got to remember that percentage figure is actually just talking about mostly mild disease. And that's important, that the Pfizer vaccine is fantastically effective, probably slightly more effective than the Oxford one, but it's more effective at preventing mild disease. And that's probably less relevant to an individual. The last thing is transmission, and we don't have good data on that yet, although it seems pretty obvious that if you reduce the number of events that are happening as quite profoundly as both these vaccines are doing, then you're likely to reduce transmission as well. So I think just have whatever vaccine you're offered, but if you have a preference of one over another, that's totally reasonable as well. They both work pretty well.
Thank you, Mark. And just a reminder to listeners, if you want the Pfizer vaccine, go out the back of the hospital and go to the Deakin Centre. If you want Oxford, go further down to Patworth. What an amazing...
Just to show I'm not biased, I ended up with the Pfizer vaccine and I was very, very happy to have it. I was delighted to be offered any vaccine at all.
Great. Thank you, Mark. We may come back to safety and some of the issues around 12 weeks, but can I go to the other end of a perspective, if you like, not from the science, but from perhaps the views of groups from the religious perspective, from the perspective of leaders of communities and what they're saying about taking up a vaccination. I'm not sure who would want to go here. Habib, you probably have lots of conversations from your observatory position about the messaging from faith leaders particularly.
Yeah, absolutely. So just as Mark said, the vaccines are rigorous, have gone through a rigorous process and regulatory processes and have been approved by all of the faith leaders that I'm certainly aware of, in terms of they do not include animal products, they do not include alcohol, and so they are in that sense safe to be used in terms of a cultural religious perspective. But the point here is also the one that Mark made, is that this isn't just about a decision around taking the vaccine or not taking it, but it's about the wider implications and protecting the health of your loved ones, your family, your friends, and your colleagues, because the stakes and the risks are far too high for vulnerable communities, such as Black and ethnic minority communities, to gamble the option of not taking the vaccine and getting the virus. And that's the balance of the argument here.
Thank you, Habib. And so you've just triggered a thought in me. On our asymptomatic staff testing here, we identified 100 positive infections from our workforce last week. So I think the point that you and Mark are making about the choices to be vaccinated or not vaccinated is the wrong way of articulating it. It's about to be exposed and possibly get COVID versus to protect yourself and minimize the impact of COVID. So thank you for that. Tracy and Ravi, is there anything else you want to say about from that perspective, from communities and their conversations? And Tracy, you touched upon conspiracy theories and in fact some more grounded, considered responses to the experiences of Black and Asian minority communities through trials. Is there stuff you want to say about that right now?
I think it's it's just a difficult issue, and I think I referenced it as a wound, and it's a wound that's never fully healed, I think, if I'm honest. And I think the only way that we will move forward with this is to address it. And the only way we can address it is by building transparency and openness around this. And then that takes the power away from the propaganda and will separate the fact from the myth, from the half-truth. Because quite frequently, as I said, our BAME communities, as has been referenced in this discussion, are more often than not disenfranchised, or certainly more often than not on the fringes of the communities and in low-income work, or on the front line, or living in these family groups, where you get multiple generations of a family living together and having access and, eating from the same pot. So, when something like this happens, it has a massive impact. And I think, as Habib referenced, I think bringing cultural ambassadors into it locally in our communities, I think as a trust, we need to do some work on developing our relationship with cultural ambassadors in the communities, developing those links and bringing them into the fore when we are designing clinical trials. So this is just in a general thing, not obviously specifically we're talking about vaccines, but I think in general moving forward, the whole relationship that we have with the BAME community and research in general, and obviously in particular, whatever fallout and regarding future research regarding this. Just from a faith perspective, if I can also say that the Christianity and the Catholic faith particularly has quite strong and rigorous views as well on some health treatments, and the Pope as well has sanctioned the vaccine. So from a Christian point of view, my local priest, there's a stream of him on YouTube, sort of, he had COVID and he's sort of saying, everybody, look, go out and get this. The Holy Father, the Pope, has sanctioned this. So, you know, it's also got that rubber stamp from, you know, the Catholic faith, but, you know, it's not just the religious side of it. We really need to pull on all the resources that we've got available to us and start building bridges and openness and transparency.
Thank you, Tracy. Thank you. Ravi, would you like to add something at this point? You're on mute. You're doing a me.
Okay, so can you hear me now?
Yes, thank you.
Thank you. It's been well spelled by Mark, Habib, and Tracy. There are a few things which I want to highlight from general, both my personal as well as my professional experience in the last few months in east of England. So just to start with this, a lot of people get confused with side effects and harmful effects. All medicines have side effects. Whether it's really harmful to prevent people from taking it or not is the question where they're getting confused. But taking vaccine, most probably some people will have a little bit of a hand pain or body pain or sometimes temperature. All these things do happen. It's not like totally there won't be anything. That actually means that vaccine is working for them. The more like sort of a hand pain or body pain or whatever, that means the body is really fighting and being, it's almost like body is exercising in the gym with the viral materials from the whatever the RNA materials from the vaccine is going into the body. So, but whether those sort of side effects, whether it's really harming them, at present, as Mark clearly mentioned, there is no evidence of severe harm done by the vaccine. So that sort of a confusion need to be taken out. So most probably once you do that, differentiating between harmful effects and minor side effects, people will be more coming forward to take the vaccine. The next one from my personal experience is like the first GP in east of England. It's a close, not sort of a very close friend. They are well known within our community and friends in the doctor circle in east of England. He is in late 60s and his daughter also works in the same GP practice. And he was very sort of a hardworking, and he started seeing everyone, even when there's a COVID scare, and a lot of GPs were hesitant in looking after the people. But he wanted to see them personally when they wanted it. The thing is, because of that behavior, to help the community, he got the virus. And within a week, sadly, he died. He was admitted in the hospital and died. And you can see the whole family and thing, because he's coming forward to help. But at that time, we were not aware of the full consequences of the virus. It's very early, around March, April time. So the whole family was a little bit distraught. And we were really he's in sort of a late 60s. It's not an age to die. But if you had a vaccine and if you're taking a vaccine, that is a preventable one. So that is one personal experience. And just last week, in our community, in the village where I'm living, one person developed sort of a fever and vomiting, and ambulance came in, checked and everything. We didn't suspect COVID. And he got an appointment in the hospital, went around 5:30 last Wednesday. Just walking from the car to the hospital, he collapsed. And when the hospital people called in and brought in to the A&E, he found dead. And he was traced for COVID and the COVID positive, and the whole family was COVID positive. We don't know how it gets into the body, and we don't know how it affects the person and the family. He's in mid-40s and have 2 young children. And he came here all the way from India only last 5-6 years back with the dream of giving a good family support and a good life for the children and the family. So it's actually distorted by COVID, I personally feel. In a sense, there are a lot of stories everyone will have, but at present, at least we have one solution. One, at least, to get tested when we develop even whatever mild symptoms are there. Isolate when you're told to. And then we have a vaccine now to take. So vaccine is one of the ways which we can actually fully test it and protect you and your family and all the friends and families around your community as well. So please do take this option. Don't neglect it with the prejudice and all sort of misinformation you're having. if government is promoting with all sort of safety measures from nationally, and the NHS is giving a free vaccine to the staff, that means they've gone through all those hoops of safety. They're giving only the best for the staff. And we are here to take the best one from our employer, from the national NHS. So in order to protect yourself and ourselves, our family and our community, this is one of the solution, or the best solution. I think it's better we should all take it when we are invited. I'll stop here, David. Thank you.
Thank you, Ravi. Can I just, before we go back to some more technical questions in a moment, a question for Habib and perhaps for you, Ravi, as well, is this thing about trust, and do we trust those people who sit in national roles or in regional roles? To some extent, Tracy and Mark are one of us. They're part of our family locally. But you guys have come in from the establishment. Is there something you can say about trust and this and the politics of all of this? And sorry, this is a really horrible question, but Habib, can I come to you first about, from your perspective, how do we build trust?
Yeah, thanks, David. So very early on during the pandemic last year, whilst I was working in NHS England, were firm of the view that one of the ways that we need to build trust, and also to make sure that the decisions that we are making at those levels, whether we're sitting around an EPPR table, emergency preparedness table, or any other decision-making table, is to have diversity of representation around the table. And that means that the decisions that are made are based upon the diversity of thought that will then be represented around the table, and will be better positioned to meet the diverse needs of our diverse communities. So that's one of the ways we do. And when we apply that principle to the vaccination, I go back to my point around having more community-based venues, utilizing the community champions and diversity we have at community level, but also when we think about those people that are actually administering the vaccine, those people need to be diverse in their representation as well. There are a number of things that can be put and should be put in place in order to build the trust, to build the confidence so that people can make reasoned decisions around this and are not diverted towards some of the misinformation and lies that are kind of doing the rounds on social media and on other mediums.
Ravi, would you, so a diversity of opinions around the table, deciding and making policy and leading on some of this. Ravi, from your perspective in a public health organisation who's so important to us, what would you say about trust?
So a lot of things are being talked nationally, so I don't want to repeat the same thing. We have a national system, SAGE, JCVI, all that sort of thing, because all these things are talked in the media very widely. But I'll try to touch on some personal stuff so it will be useful locally. So as a BAME community, we all come with some sort of a baggage, because we are not, majority of us, we're not either born and brought up here. Even if you're born and brought up, we are brought up by parents who have some sort of a knowledge and belief and culture and religion, which is not part of the England or English system. So that baggage actually confuses us from the information what we are getting here nationally or locally. So as long as like people understand that particular baggage, what we already have, is confusing us and trying to, that might lead to mistrust or distrust when that comes into sort of a play. As long as we are aware, both in the BAME community plus other leaders like you here, and try to make sure people understand and separate those baggages and understand the actual message, why and how we are actually getting this vaccine and why we need to get this vaccine, because we are here and the reason for that to protect us and our family, then more people are willing. But main thing we need to understand is misinformation, if it goes first, that will be the foundation. So we are actually digging that foundation in order to put our information back. So we should be in forefront before the misinformation hits these people. So that is where the social media comes in. So wherever we see a small misinformation or disinformation, or most probably it might tweak the actual information, we need to go faster than the misinformation to reach the community before that as a foundation, so that they're prepared to handle the misinformation. So I don't know whether I'm making sense or not. Just that is our sort of a role in order to use that. So we try to do this in all sort of vaccination, not COVID vaccination. Coming to the NHS trust, we tried different strategies which works in order to treat this misinformation or trust. One thing I want to highlight is people as people, we all actually trust our peers. So if we encourage our own peers to immunize our peers, for example, if you identify really a known BAME person, either Black African or community in a particular area in A&D or whatever department, identify few people who are actually champions in that particular area, train them, put some investment on them so that they are fully aware and they can actually be the champion and try to do either information communication, or actually they can immunize within that particular community in that particular department. So in a sense, it's almost like defranchising in order to make sure we have investment in the peers in order to actually deal with their own peers. I'll stop here, just sort of another option I was trying to say. Thank you.
Thank you, Ravi. I'm aware we're about 2 minutes from the end. Mark, would it be unfair to ask you to respond to the question about the 12-week pause between the two vaccines, and whether that would change your view about getting the first?
Okay, yeah, very happy to talk about that. So I've had my first, and I'm very comfortable waiting to 12 weeks. And I had the Pfizer vaccine. So if you're having the Chadox vaccine, the evidence is better with 12 weeks, actually. So in fact, the better thing to do is wait 12 weeks. It's dead simple. If you're having the Pfizer vaccine, it's a little bit of a calculated gamble they've taken. And the calculation here is that actually in every other vaccine, or in the majority of vaccines, leaving a longer time between boosters is a good thing. Usually the reason you do it in short time frames is partly just because of ease, because you're more likely to get someone turning up 4 weeks after than remembering 3 or 6 or 12 months down the line. The other calculation there is that it's better to give double the amount of people a slightly lower protection, bearing in mind how effective the vaccines are, than it is to give half of the people 2 doses and get perfect protection. And that's, so on a personal level, that's where I sit on it. I'm quite happy to give my second dose away, get it in 12 weeks time, if it means somebody else gets a shot at being protected. And I don't think it's going to massively impact on protection, but the data isn't there yet to back that up. So that's the calculated gamble bit of it. But I think if you think of it this way, you know, if you've got a colleague sitting next to you and you've had 1 vaccine already, and you're low risk anyway, we're all pretty low risk because we're young and we're reasonably fit. So we're starting off low risk and we become lower risk when we're vaccinated. Would you really want to have that second shot, or would you give it to that other person? And I would give it to that other person. So that's, you know, I'm relaxed about it, and all of the really good immunologists I know are very relaxed about it as well. But the evidence isn't quite there yet, so it is a little bit of a gamble.
Thank you, Mark. Really, really nicely put and reassuring for those of us who have had the first, which is great. Listen, I'm going to have to bring us all to a close. Can I say there's a whole number of questions. I think we've got like 20 questions that we haven't answered. So what we're going to do is Monica's taken some screenshots. We'll pull them together. We'll put some words around them. They are really important messages about what's important to this community, to our colleagues right now. We will use them. Thank you. We'll continue to link in with the BAME network and the wider community on this. Can I close then by saying thank you so much to our 4 wonderful, really informative. After all that's said about COVID, there's still much more to learn about it and our response to it. So thank you, panel, for being magnificent. Can I thank Nikki for managing the technology and a wider range of things, and to Monica for organising this. I mean, I want to close by saying, as we started, we want to keep our workforce healthy and safe. and we want to minimize inequality. There are questions around how inequality pops up all over the place. It pops up as it relates to health. Please, let's not let this next thing be something which promotes inequality. Let's not let an inequality of take-up of vaccine become the next scandal which hits on equality, diversity and inclusion. And if there's stuff we can do to help take up for our people, our family, our communities, then please do continue to shout. I hope you all feel able to make informed decisions about taking up the vaccine. And dare I say, I hope the decision is that you do take the vaccine with us and protect yourself, your colleagues and the patients we serve. No doubt I've said lots of clumsy things and I've asked lots of complex questions. I hope you'll forgive me if I've got things wrong. But thank you very much indeed for our panel and for all those delegates who joined us today, and look forward to seeing you very soon through other means. Thank you very much indeed.
Thanks.